Oturumumuzun konusu klinik tam yanıt oranını artırabilir miyiz?
Bu 2 gün içinde Sayın Doktor Oktar Asoğlu'nun başkanlığında aslında çok önemli bir konuyu multidisipliner olarak tartışma şansımız oldu ve bu başarılı yöntemleri daha da artırabilir miyiz? Tam yanıt oranlarını artırabilir miyiz? Bu konuda neler yapabiliriz? Ya da gelecekte bizi neler bekliyor? Bunu tartışmak istiyoruz. İlk konuşmasını yapmak üzere Dr. Rob Glynne Jones'u davet ediyorum. Bekle gör için radyoterapi yanıtı artırılabilir mi? Professor Jones.
Okay. Thank you very much. Can you hear me? Sounds a bit loud, actually. Okay. So my take on this morning is that complete clinical response is really important, but it may actually depend on the route by which you get there. And I think the point was Mel made that big tumours tend to fragment when they respond, and smaller tumours tend to resolve back to the endoluminal surface. And if we do increase the dose to the primary tumour for bigger tumours, we may have a different natural history. Anyway, I'm going to talk about enhancing response with radiotherapy. So, I think as we said yesterday, chemoradiation is a potentially curative treatment, but it wasn't intended to do so. It was intended to shrink the tumour a bit and allow the surgeon to get on with things. So currently, 15 to 25% will get a pathological complete response or a complete clinical response, but quite a lot of patients still fail to respond. So most patients, the majority of patients, will not achieve a sustained local control unless surgery is added, some form of surgery. And despite the low doses that we use, 45 gray, there is still considerable morbidity associated with that, and the late morbidity from radiotherapy is contributed to, but not usually caused by the surgery, and vice versa. And I think it's important to remember that. So we've got lots of different strategies: external beam, contact therapy, brachytherapy, and cyberknife. And we have all of those available in my unit, except the contact, which I have to send off to Guildford if we want. But at the same time, we've got this ability to do this, but we do not want to badly adversely affect long-term functional outcomes. So we can improve the quality of the radiotherapy. We can dose escalate external beam. We can use brachytherapy or contact to boost, shorten the overall treatment time, simultaneous integrated boost, and we can do other things. But we're going to focus on radiotherapy. So again, I'm kind of focusing really on larger tumours and whether we should be looking at larger tumours and smaller tumours separately. Larger tumours seem to have a lower rate of pathological complete response and also a lower rate of complete clinical response. And there's, as has been mentioned this morning, there's less correlation between clinical complete response and pathological complete response because you get big ulcerated tumours which don't seem to go away in quite the same pattern and do not give you that nice white scar quite so easily. And so we may need to wait much longer. Again, the issue is how long can you wait? And I think this is some nice population data looking at small tumours, small early tumours, there's only about 200 patients, or larger tumours where there's about 1,000. And the patterns of response are clearly rather different if you have smaller tumours and larger tumours. I usually show this slide to the surgeons to say, if you haven't had, if you haven't had a sufficient response away from your circumferential margin by about 12 weeks, you ain't going to get it. So we're going to have to do something differently here. So if we're going to reduce the late effects at the same time, we'll need to obviously identify the tumour. and those organs at risk, which are going to be the problems for us. And then we need to accurately hit the target, and we need to accurately avoid the OARs. And I don't find that always as easy as it's set out to be. IMRT is said to be very easy. We just have a nice modified fields, and we don't hit the OARs. But actually, we have a much higher modal dose to the small bowel in some cases, and I think we are, in some cases, causing more problems than we think. I think there's limited scope for dose escalating large advanced tumours and avoiding surgery without compromising late function. And I don't have a great deal of data to show that, but it's certainly my impression. So if we look at contact or brachytherapy, we can put quite a high dose into primary tumour. It's very difficult unless you have small tumours. The contact therapy you can only get in if you can angulate the applicator enough, so you can't really treat low tumours, you can't treat tumours above about 10 centimetres, and you have to have small 2 or 3 centimetre tumours which do not encompass the majority of the circumference. In principle, IMRT can do the same, but again, you start to think about what about the draining lymph nodes, and should we be dose escalating the radiotherapy to those as well? So there's a recent paper, systematic review and meta-analysis by Burbach, and the conclusion of that was dose escalation above 60 Gray results in high PCR rates and acceptable early toxicity. But I wasn't sure that the paper actually justified. If I'd been reviewing that, I would have certainly said, I don't think the conclusions are justified by the data that you show. Because if we look at the evidence, we can think about randomized trials. So probably the best randomized trial with the most longest follow-up is Jean-Pierre Gérard's Lyon 9602, where they gave slightly unusual fractionation of 39 Gray in 13 fractions, and then either did that alone or boosted to 85 Gray in 3 fractions. 85 Gray is a pretty big dose. It's and it's only deliverable in contact therapy because you have a very superficial dose for that, and also for very small tumours. So they had to be endorectally defined, clinically T2, T3, less than 2/3 of the circumference, and about a quarter of them were clinically U2, and nearly all of them were less than 50% of the circumference. So it made a small study, but quite a big difference. 1 complete clinical response in the external beam alone versus 11 when you added contact therapy. And permanent colostomy in 63, that's about 2/3 of the patients with radiotherapy alone, and about 1/3 with those with contact. So certainly it seems to make quite a big difference, and there's good long-term follow-up for those patients. But they were quite small tumours and quite early tumours. If you look at the other 3 randomized trials which look at dose escalation of the radiotherapy, probably the best one of these is Anders Jacobsen from Denmark, where he gave 50.4 Gray with UFT, and then the other arm had 10 Gray in 2 fractions of brachytherapy in weeks, integrated into weeks 4 and 6 of the radiotherapy. And as you can see from that, the path-CR rate was identical in both arms, whether you looked at intention to treat or whether those per protocol received the actual dose. And the other 2 randomized trials don't, to me, give a huge signal that pathological complete response is going to be different. Now, these studies are all biased because they all have surgery, and they have quite early surgery at about 6 weeks, 7 weeks. So that may reflect this, that maybe for the bigger tumors, we may not simply be waiting long enough. But his take was, we found no effect on T4 tumors, significant improvement noted in the major response for T3 tumors. And indeed, if you look at the major response, if you put TRG1 and TRG2 together, there's certainly a significant difference for those patients, which kind of suggests that maybe if you'd waited a bit longer, that some of those patients may well have gone into complete clinical response and certainly had a complete pathological response. Interesting thing from that study was that most of the major response is in the small tumours, less than 3.7 centimetres. And I think when you look at, I don't know, neither of you actually show what the initial size in your series are, but certainly Haber-Gamma's has got bigger over the years, but the actual median size for the Haber-Gamma data is really quite small compared to what we would think of as an average rectal cancer requiring chemoradiation. So there may be an issue about size. Interestingly, this is the data regarding local control, and those patients with the brachytherapy actually did worse. Bit counterintuitive. How did guys that you cranked up the dose, you had a better response, but your local control was worse? Well, they were quite poor prognostic tumours because more than 2/3 of these patients were within 1 millimetre of the circumferential margin, so they're really quite advanced tumours, and 92% of them were within 2 millimetres. Many of the big randomised trials have a large proportion, and maybe 50% of their patients, where there's a 5 millimetre distance between the tumour and the circumferential margin. So these are really quite bad, nasty tumours. And again, as I said, the pathology may have been a bit soon at 6 to 8 weeks. Her model showed that if you wanted the dotted line is TRG1 and 2, and the solid line is PCR. So the model suggests that if you want to get 50% of your patients into PCR, you will have to give about 90 gray, which is pretty difficult unless you're giving contact therapy, I think. So recent data, which is a sort of pooled analysis of what we've been doing, was published in Acta Oncologica, and showing that the radiotherapy dose, the clinical T stage, and the time interval were significant predictors of pathological complete response. And I think this is quite a nice paper showing that if you cranked up the dose from 45 gray to 50, you would increase the pathological response rate a bit. And if you cranked it up from 50 to 54 gray, a little bit more. But you're probably getting to the steep part of the curve there for the majority of these patients. So, given that we didn't see much improvement in the PCR rates in all those trials where you added oxaliplatin, and the only significant one really was the Accord trial, there is a suggestion that the increase in PCR rates that was achieved in the Accord trial was due to the increase in radiotherapy rather than the increase in the addition of oxaliplatin. In that particular study, they also looked at the sterilization of lymph nodes, and again there was a suggestion if you cranked up the dose to 54 gray that you would marginally impact on the negativity of lymph nodes. But again, you're on the steep part of the curve, and for I don't know that we know what the difference between 45 gray and 54 gray in terms of function does, but I think you're approaching a cutoff point at about 56 gray. So, very nice paper where the Danish group then decided that they would take small tumours, increase the dose to the primary tumour to 60 gray in 30 fractions, and the elective lymph nodes to 50 gray in 30 fractions with UFT, and give a single 5 gray boost. And they had a very exciting complete clinical response rate of 40 out of these 51 patients, which is a very high complete clinical response rate. I think, though, it's worth pointing out that the majority of these patients, again, were T2. The T3 patients, they didn't divide into subclassifications, but the diameter of most of these patients was pretty small, 2.8 centimeters. I don't ever remember treating a patient with 2.8 centimeter tumor. I don't think I've ever been asked to do it. So early tumors, But I think the results are encouraging. Again, there are a few distant metastases and a few local recurrences. And again, we await really the long-term function in these patients. There's some evidence that you get some bleeding, and I think it will be really important for us to see an update of this data. But overall, about the same number of patients. 23% have had a local failure, as many of the other studies, and a small number have metastasized. And that's pretty well identical to the watch and wait database that you presented. So cranking up the dose would seem, in that case, in small tumors, that even though you got there a slightly different way, not to matter. Other studies have tried with external beam, again, similar sort of patterns, 60 grain, 30 fractions, 54 grain to the prophylactic lymph nodes, but have been rather less successful. So it may have been the brachytherapy in some of those other studies. Primary tumor downstaging, nodes downstaging about 85%, but they concluded they didn't see a great advantage in terms of either downsstaging or downsizing, cranking up the dose, and there's no real functional data added from that. The other paper, which was recently published, comes from Jean-Pierre Girard's group in Nice, where they show us a 12-year series. There are 3 groups there. I'm not going to go into the sort of, the group 3 was trying to render patients suitable for resection, and group 2 was really taking earlier patients and seeing whether you could actually get organ preservation in these patients. So small number of patients over 12 years, 45 patients. So complete clinical response they achieved in 96%. And 3 of those developed a local recurrence. I've read this paper quite a lot of times, and I find it quite difficult to understand because 14 of them had surgery. And I'm not quite sure why, if you had a complete clinical response, why they would then go and do surgery, but it's a bit curious. Only 57% of these patients had an MRI, and I suspect that most of the T3s were perhaps T2s, but there we go. So, but anyway, successfully, the rate of organ preservation in this group of patients was almost 90%, and they had good bowel function in 36% on your MSKCC scale. Although I've always thought that good function allows you to wear a nappy, I think, which I personally wouldn't think I had good function if I was allowed to wear a nappy, if I wanted to. Dose per fraction in that study with the contact therapy was 30 gray. The paper says there were dose modifications depending on tumor response. So if you had a good tumor response, you gave a bit less. If you have a bad tumor response, you gave a bit more. So you could actually give 100 gray to resistant tumors who are over 3 centimeters in diameter. So it's a little difficult to actually reproduce this data. I don't think that I could take what they've done into my clinic and say I could confidently reproduce that because it seems a bit idiosyncratic for lots of things. The other thing I think is interesting is the patients are always referred to the radiation oncologist, so there's a big selection there. And for 45 patients in 12 years, it's clearly quite selected, have to be within 10 centimeters, less than 4 centimeters, half the circumference. And again, this is the issue that Dr. Patey talked about this morning. We really don't know what the denominator is there at all. And I think that's really quite a shame that we don't know that. So, if you do dose escalate, points I would make is, does it matter how you get there? Do you have the same local regional outcomes if you crank up the dose and you get a complete clinical response? Do you have the same distant favorable outcomes that we see from watch and wait if you increase the dose to big tumors? And what is the surgical late morbidity? Because very few of these studies actually give you decent functional outcomes. with or without. I mean, I think Gerard's data with the local excisions and without the local excisions kind of gives you more data than I've seen anywhere else. But again, it's relatively little data there, and most of the others don't give you that. So in terms of dose response, I think it's likely to be different for small early tumours and node negative tumours with less than 50% circumference. You could have something like this in the blue rather than the previous APELT, so you could have a different scale there. But certainly in the APELT data, the majority of patients achieving a pathological complete response were clinically node negative. They had good MRI, good quality MRI, and I think most of those patients were clinically node negative, whether that reflects a true state or not. So personally, my view is that radiotherapy has got modest dose escalation promise for the small early tumours, rather than picking the winners and cranking up the dose there. I think you're going to be better to select some patients with low rectal cancers where the surgeon has said, I am going to do an AP excision, there isn't really a choice here, and to dose escalate those patients in a planned way. And I think probably we need some trials there for that specific group of patients where they're defined to have an AP excision of the rectum, and seeing what the functional outcomes in terms of sexual, bladder, and other things will be if we do that in the future. Thank you very much.